Well, welcome everyone this morning or the afternoon, depending on where you're joining us from, as some of our illustrious speakers. So to this February 4th World Cancer Day, which is a leading international awareness day for cancer and held on February 4th every year. And this is our second year holding a webinar, and we're actually an official activity of World Cancer Day, which is a global uniting initiative led by the Union for International Cancer Control. And hoping to raise worldwide awareness and improve education, catalyze personal, collective, and government action. And basically all of us working together to reimagine a world where millions of preventable cancer deaths are saved, and people can access life-accessing cancer treatment, and care is equitable for all. And this year's theme is actually closing the care gap, and all about raising awareness for equity in this gap, and make sure that everyone has access to and is aware of cancer, no matter where you are, who you are. And we think this is really fitting for the OCAL work. So for those of you I haven't met, I'm Kimberly O'Connell. I'm an occupational hygienist. I lead out the occupational hygiene discipline team at OCAL, and I'm the executive director of the Northern and Eastern clinics. I'm also co-chair of the Disease Action Plan, where this is very much one of the services, are very fitting for that group, or the Occupational Illness Steering Committee, which is converted to now co-chairing with the Ministry of Labor Training and Skills Development, which brings together the whole system partnership in disease prevention initiatives, of which this is one. So the majority of our work at OCAL, as some people and hope many know, is looking at objective evidence-based opinion on work-relatedness of disease, and a lot of those are cancer. So we hope today highlights, the importance of OCAL's role with partnerships like the Occupational Cancer Research Center, and sheds a light on rare cancers for us. So without further ado, let's get our day underway, our morning. You are welcome. There's some logistics happening in the chat. Feel free to write your questions there. Depending on how many we have, we've been having much better luck at and trying to be a bit more interactive. So you should be able to take your mute button off we're going to have questions following each speaker, and then all of our speakers today are able to stay for a panel discussion as well. So we are looking forward to that, and we will, again, you can write questions in the chat, and we hope that we can keep video for bandwidth and may be able to unmute yourselves for questions and for the panel discussion. So welcome again. And without further ado, I'd like to introduce our first speaker, Dr. Giovanna Sturtevant, who's trained in occupational epidemiology, surveillance, and cancer prevention. She completed her PhD with the University of Toronto Institute of Medical Science and the Occupational Cancer Research Centre, Ontario Health, where she examined prostate cancer risk in working men across multiple population data sets in Canada. Giovanna previously taught cancer biology and research method courses at Ontario Tech University, and is currently assisting with teaching occupational epidemiology at the University of Toronto. She is the scientific lead for surveillance at the Occupational Cancer Research Centre, leading the Occupational Disease Surveillance System team. And when she's not working, Giovanna spends most of her time with her two daughters. So welcome, Giovanna.
Thank you. It's a pleasure to be presenting today on World Cancer Day, but also thank you to OCAL for inviting us at OCRC to present today on rare cancers in Ontario. And my presentation will be specific to examples from the Occupational Disease Surveillance System known as ODSS or ODIS. So I just want to start with a little bit of background, talking about what rare cancers are and how they are different from common cancers. So there is a lack of familiarity with these cancers by healthcare providers, which can often lead to delays in diagnosis. So studies have found that delays from the time of appearance of the first symptoms of a rare cancer to the time of diagnosis is often delayed. There's also a lack of treatment options for rare cancers, which can result in poor outcomes for patients. And healthcare providers don't necessarily understand rare cancers and their treatment because funding and research are often limited, and there's often a low number of patients, which make clinical trials difficult to actually conduct for rare cancers. And support services and information for people with rare cancer is often unavailable or limited, which can contribute to patients feeling more annihilated, confused, or stressed when diagnosed with a rare cancer. So the next few slides, I will be referencing the Ontario Health, previously Cancer Care Ontario, Ontario Cancer Statistics, which talks about the burden of rare cancers in Ontario. So how are rare cancers defined? So this is fewer than 6 cases per 100,000 people a year. And rare cancers are thought to have a genetic component and may often occur more in younger individuals, although this is not always true. For examples like mesothelioma, which I'll talk about today, we know this occurs in older individuals, and there's a well-established occupational link to asbestos exposure. And we know that approximately 90% of people who develop mesothelioma in Ontario were born prior to 1950. So this is just to give you an example of rare cancers, the proportion of new cases due to rare versus common cancers in Ontario, so between 2012 and 2016. And what you can just see here is really that rare cancers accounted for about 20% of all new cases diagnosed between 2012 and 2016. And among males, rare cancers accounted for 23%, whereas in females, rare cancers accounted for about 16% of new cases. And figure 2 shows you the proportion of new cases again. This is rare versus common, but now this is by age group. So you can see that people diagnosed with rare cancers were almost 3 times more likely to be in the younger age group of 15 to 39 years than those diagnosed with a common cancer, which occurred more ages 60 to 79. But again, there are exceptions to this, such as mesothelioma, which I'll talk about in the next few slides once we get into examples. So these are examples of rare cancers. These are some of these we can actually look at in the surveillance system that I'll be talking about today. But just to give you an idea of what rare cancers are, and so for example, like male breast cancer, we know that female breast cancer is quite common, but male breast cancer is rare. So this brings me to occupational cancer surveillance. And there are some significant challenges when we're looking at occupational disease surveillance in general. It's difficult to capture occupational diseases in an accurate and timely manner that's in tune with evidence-based prevention, which is an ongoing challenge. But large data sets like our surveillance system, ODSS, which I'll introduce in the next slide, help to fill this gap. And prior to the development of ODSS, there were no occupational disease surveillance systems, including for cancers, to identify high-risk occupations or populations and to target prevention efforts in Ontario or even in other Canadian jurisdictions. So occupational diseases have generally been excluded from traditional workplace surveillance, which primarily focuses on injuries and has relied largely on workers' compensation data and also population surveillance systems, so for example, like the Public Health Agency of Canada's chronic disease surveillance system, don't capture information on where people work. The second challenge is when we're working with workers' compensation data, which can present an incomplete picture because we know that only a small proportion of occupational diseases are recognized and even fewer are compensated for. So if you take a look at our research brief that's published on our occupationalcancer.ca website, we have a research brief on mesothelioma in Ontario. And you'll see that in the last 5 years prior to 2019, there were approximately 240 cases diagnosed annually in Ontario, while approximately 80 cases were compensated for annually. And this discrepancy is mostly because claims are not filed. And although we know that overall rates may have plateaued, case numbers are unlikely to decrease, and they may even increase as the Ontario population ages and grows. And also, this is important for women as well, and this may have important implications for compensation. And the last point for challenges in occupational disease surveillance is that none of the large Ontario health databases, including tumor registry information, hospital data, and physician billing, contain occupation or industry information, which is often a significant challenge because we know that adults spend a third of their life working and spend a majority of their working or waking hours in a work environment. So this is really to introduce our occupational disease surveillance program, known as ODSP. And it's a unique system where we're able to identify and monitor trends in work-related disease in Ontario. And this system was created in 2016 by linking existing provincial health databases with job information. In order to study occupational diseases, cancers, and other non-cancer diseases, and really to inform prevention activities. So we roughly follow 2.4 million Ontario workers up to 2021 for other diseases and up to 2020 for cancer outcomes. And this is really linked to the WSIB compensation data that has a record of their occupation and industry, and this is linked to the Ontario Health databases. And we can track over 20 cancers and 9 non-cancer diseases, and it's also linked to the Ontario Cancer Registry. So I just wanted to note that this is funded by the Ministry of Labour, Training and Skills Development and the Ministry of Health. And today I'm going to focus on rare cancers, but you can check out our website at ODSP just to see what other projects we work on in the surveillance program, and if you're interested in other cancers or disease
because outcomes. I'm going to go on the 21st.
So this is the occupational disease surveillance system that I just spoke about, which falls under our ODSP program. So again, just to describe it, we can look at 2.4 million workers, but we can look at hundreds of different occupation and industry groups and multiple health outcomes, including rare cancers. And these are examples of rare cancers that are captured in the ODSS. These are the specific cancer examples that I'll speak about today. So mesothelioma, male breast cancer, cyanonasal cancer, salivary gland cancer, and bone cancer. And we can see that there's over 150 cases for each of these. They are rare. And one thing to note is that we can't report any groups with less than 6 cases, which tends to happen as we narrow down our occupation and industry groups into very specific job titles. So just to keep that in mind as I go through some of the examples. So mesothelioma, this is to really show you the groups that are at increased risk in our ODSS. And just a little bit of the background information. The age of diagnosis for these individuals was 59 to 75 years in the ODSS. And we do have a report, the burden of occupational cancer in Canada, burden report that's published on our occupationalcancer.ca website, which estimates that approximately 80% of mesothelioma cases are attributable to occupational asbestos exposure in Ontario. And despite the ban on asbestos use in Canada, we know that because of the long latency periods, mesothelioma will persist for many decades. The greatest risk of mesothelioma was observed in the ODIS for workers employed in construction, asbestos mining, and some of the metal industries and occupations. So here you can see construction and asbestos. So findings here show you the percent increase for mesothelioma in workers compared to all other workers followed in the ODSS. And statistically significant at 0.05. So construction, for example, there were a number of groups where we can see increased risk of mesothelioma. And for example, we know that insulating and pipe fitting and plumbing workers have the highest risk of exposure for asbestos. And this is really because of the widespread use of asbestos in insulation and pipes in buildings built prior to 1980. But there were also other trades at risk that you can see here, and this may be due to handling asbestos-containing materials, working in environments where those materials are used for renovation, for maintenance, or demolition of older buildings. The other important finding is for asbestos mining, which you would expect to see, although asbestos mining is much smaller in Ontario than it is in Quebec. The ODSS results here show us that asbestos miners in Ontario are at a very high risk for mesothelioma. So this is an expected finding given that they're exposed to asbestos exposure. So the other two groups are metal-related work and motor vehicle manufacturing and repair. So working with metal products can involve extreme heat in many processes such as forming, shaping, and welding. And asbestos was a common insulating material used in machinery, equipment, and especially protective clothing for hot metalworking processes. So it's used in gloves, jackets, masks, aprons that essentially contained asbestos, because this would effectively protect workers from the extreme heat. And some metal products would also be finished with asbestos containing coating for durability and fireproofing. So these were important findings in our study, where we see that metal-related workers had an increased risk for mesothelioma. And this is also shown in previous studies as well. For motor vehicle manufacturing and repair, we know that, for example, brake and clutch components have contained asbestos for many decades, and workers involved in vehicle repair and maintenance were observed to have an increased risk of mesothelioma in the ODS surveillance system. And many vehicles have asbestos-containing materials, and exposure from repair of these vehicles can continue to put these workers at risk. So the next group of interest is for breast cancer. So we know that, female breast cancer is a common cancer. We had about 17,000 female breast cancer cases that were captured in the ODIS. But for male breast cancer, we had 492 cases. And really what I'm going to focus on are the results that were similar in both males and females in the ODIS. And it's well known that breast cancer, is commonly diagnosed in women. It counts for less than 1% of cases in men. There's many risk factors associated to breast cancer that have been studied in female breast cancer, specifically related to family history, BRCA, genetic mutations, reproductive and hormonal factors, and some occupational factors like night shift work or endocrine disrupting agents. But what's important is that, we're seeing similar findings for male breast cancer in nursing and other healthcare workers and education workers. An elevated risk of breast cancer have been previously observed in workers involved in our female nursing workers involved in night or rotating shift work. And we also know that nurses are exposed to antineoplastic agents that are drugs that are used to treat cancer and can cause DNA damage. There's also other medicine and health workers who have an increased risk of breast cancer. And this includes medical laboratory and radiologic technologists. So these workers could be exposed to ionizing radiation or ethylene oxide, which is often used in sterilization of medical and dental equipment, and both have been previously linked to breast cancer risk in females. So this is sort of interesting because we're seeing similar findings for male breast cancer, even with such a small number of cases. So for education and related industries and occupations, we do see increased risk for males as well in the same groupings that we did for females. I don't have the female results shown here. And previous studies have reported increased risk of breast cancer in females who are in these professional occupations. But there's no clear indication of what exposures could be involved. Some findings are related to sedentary behavior or lack of physical activity. And I think this is primarily because we know physical activity is an important factor for breast cancer prevention. But it's still unclear as to if this is something that is linked to why we see these findings in both men and women. But also another area could be increased stress in these occupations. However, the evidence is quite limited. So the third cancer that I'm going to talk about is cyanonasal cancer, and I just want to point out that for mesothelioma and male breast cancer, we've seen the evidence in the literature, and our findings do align with those two rare cancers. However, as I go through the next few, you'll see that the evidence is quite limited. We don't really know some of the exposures that are involved, and because we're getting down to smaller and smaller number of people who are diagnosed with this cancer, and we're unable to really narrow down their job title, it is more challenging to really interpret the results. So here for cyanonasal cancer, for those who don't know, it's a cancer of the nasal cavities and surrounding sinus tissue, and it is quite rare, but it has been linked to inhalation of certain dusts and metal compounds, which are known causes of cyanonasal cancer. But because of the rarity of this particular cancer, many groups had a relatively small number of cases, so the results should really be interpreted with caution. And so for example, one of our important results is in wood processing and fabrication, where we see workers in wood-related work primarily exposed to wood dust. And in addition, these workers could be also exposed to other carcinogens, such as formaldehyde used in wood products or fiberboard, or during pulp and paper processing. We also saw results for increased risks for metalworking occupations, which may have exposure to nickel or chromium-6 compounds, which have been linked to cyanonasal cancer. But there may be varying levels of exposure in these jobs. And we already know workers are exposed to metal fumes and dust during specific jobs like welding and flame cutting. And the last group for cyanonasal cancer are the construction groups. Some workers in construction may be exposed to wood dust, chromium-6 compounds, nickel, formaldehyde, and we know construction workers are exposed to many different agents. So it's very unclear as to what exposures are involved that would be linked back to cyanonasal cancer in these workers. And we did see some other additional groups with increased risk of cyanonasal cancer that aren't shown here. And this is because the case counts were too small for us to really publish the findings. The next group is salivary gland cancer. So I won't spend too much time on this because Sarah Rhodes, who's presenting next, will be talking more about salivary gland cancer and some of the results. But occupational exposures that have been reported to be associated with an increased risk of salivary gland cancer include asbestos mining, manufacturing of rubber, exposure to metal in the plumbing industry, and some woodworking occupations. And there has been a study that showed a high relative risk for developing salivary carcinoma in workers exposed to nickel, chromium, cement dust, asbestos, so a few of the different agents. But we had very small numbers in our cohort, so we can't really assess this any further in our occupation and industry groups. We were unable to dig any further into these groups, and we did see some interesting findings that you can see here, like material handling equipment operators, some of the mining work, or specifically excavating, grading, and paving related occupations. And these may be interesting findings, but given they're quite small groups, it's very difficult to interpret. But I wanted to show this example since it's important to also show examples where sometimes we can't capture the rare cancers even in a large surveillance system like ours, and it's more difficult to understand the possible occupational exposures involved. And the last one is bone cancer. So the advantage, here is that we're able to still look at some of these groups, even if we don't know what the occupational exposures involved are, or if they're linked to specific cancers like bone cancer. And we know that, if we saw bone cancer in healthcare workers, we might link it to ionizing radiation exposure. However, we didn't see anything in our healthcare workers. We did see how findings in mining, metal-related work, specifically in rock and soil drilling, boilermakers, and in mechanics and repairmen who have high risks of other cancers already in our surveillance system. But again, these results have to be interpreted with caution, and some of these are not published on our website right now, as we do have to go through these results and try to interpret them looking at the evidence that's available right now in the literature. So in conclusion, there's a couple of things that I just wanted to talk about to summarize our findings. The surveillance system that we have is quite unique, and it's large enough to examine even moderately rare cancers that I've shown. And although we've got small numbers for specific jobs, which we may not be able to report, it's an advantage to have such a large surveillance system to be able to even examine some of these cancers. And we do update the surveillance system on an ongoing basis. So right now we do have data up to 2020 for cancer and up to 2021 for other health outcomes. And something to note is we don't have information on other factors like reproductive factors or race or ethnicity, income or education, although occupation is still a good surrogate for socioeconomic status. So this may provide some understanding between groups regarding demographic factors, even though we can't capture that in the surveillance system. We do see clear patterns when we see relative risks that are large, or when we know the cases are related to occupational exposures like mesothelioma, but the results still need to be interpreted with caution since we're looking at such small numbers for some of these rare cancers, and there's little known about the causes or occupational component involved. Many of the cancers are often understudied, and when there's little known about the causes, the results can be hard to interpret, but you can definitely find more information on some of our cancer sites on our occupationalcancer.ca website if you'd like to see even a broader spectrum of the industry or occupations that were linked to these cancers. So I'd just like to acknowledge the ODSS team that's worked really hard on the surveillance system here, and OCAL for inviting us today to speak, and the Occupational Cancer Research Center. If you'd like more information, as I mentioned, please do visit our websites. We do look at other cancers, but also if you want more information on these specific rare cancers, you can look at our ODSP website. And we also have infographics by sector and exposure on the OCDisease website that's done with the Canadian Centre for Occupational Health and Safety. So you can definitely find more information or reach out to me if you'd like more information on some of the cancer sites we look at. Thank you.
Thanks so much, Giovanna. We are so blessed to have you and appreciate our partnership with the Occupational Cancer Research Center. And I did just want to invite, we have tons of time, if people would like to throw a question for you in the chat, or unmute if you wish and ask your question. I did want to point out that a lot of the OCDisease prevention work that we're working on at the system level depends on the data and from the surveillance system and the Occupational Cancer Research Center. And I was interested, and thanks for pointing out all the challenges with that data and how we know these numbers are so much larger than what we're able to see through the surveillance systems that we have. But one particular mention, you talked about difficulty with small numbers for privacy reasons. Can you expand on what you meant by that for privacy reasons?
Yeah, so we don't report case counts less than 6 in specific job titles, and we've really followed sort of what Statistics Canada follows, and I think it's just so we can't identify the individuals in those specific occupations, and that's sort of our rule of thumb for trying to identify when you narrow down occupation and industry groups into minor level, which is really the narrow job titles that we can retrieve. So we've got sort of the broader groups, and then as we narrow them down into, say, Boilermakers, for example, we don't like to report less than 6 cases in that job title, just because that's sort of the reporting that we followed, that other organizations and, for example, Statistics Canada does follow, and they follow that just because they don't want to be able to identify individuals in that specific occupation group that's designated by that job title. So we do follow that. And the only thing is, with some of the rare cancers that I spoke about today, even if it's less than 6 cases, some of them, if they've got 0 cases in that job title, we're really pulling out, a few numbers that we're able to report on. So sometimes it isn't also really going to tell the story that maybe people want to hear, but we do like to still report at a broader level and then try to interpret the findings based on what's known in the literature. So there are some challenges with that, but we do, as you saw, we do have quite a number of cases for each of the rare cancers that I spoke about. So we are still able to report at a broader level, which I think still provides some level of understanding, and we can compare that to the current literature and any studies that do come out.
Thanks, Giovanna. And we do have a great question. I might bring this up to the whole panel later, but we'll ask it to you right now from Carmel about how health and safety and environmental professionals relay this info back to workplaces, because they're used to presenting the issues over the urgent controls, and I love this question, and maybe we will bring it back. But if you want to give your edge on it now, Giovanna, and we can ask the rest later, because this is what we're really trying to do, is make people care. And it's hard when there's no blood on the floor. When things are more chronic, that people are being exposed to issues. How do we get this? So yeah, go for it. What do you think for Colonel?
Yeah, no, this is a challenging area. So we definitely are trying to disseminate our findings as much as we can so that stakeholders and other groups can use this as tools to, use in their workplace and kind of provide awareness or education on these specific topics. So if you also look at our Disease Stats website, that's that our partnership with the Canadian Centre for Occupational Health and Safety, we did publish specific exposure data and disease outcomes from the surveillance system in very visually appealing infographics and things, so that could be used and we could disseminate the findings from our surveillance system with exposure.
And Lisa, good point. We'll just wait to catch Giovanna again. Of course, we want to urgently control, and you'll see how we roll that in with our next presentation as well. And Daryl, hi Daryl. Thanks. Yes, and Daryl's asking if industry sectors and occupation are organized by NAICS and NOx codes. And we'll if we get Giovanna back, we'll let her answer that from, or Paul, you're on, you can unmute. If you're there to answer that, I want to say yes, but I'd rather it come from the OCRC. So maybe we'll hold that for our panel, possibly at the end, that question, Daryl. But